Hello everyone, I'm Dr. Deed Harrison. I'm president of Chiropractic BioPhysics Seminars and Technique, and I'm also president of Chiropractic BioPhysics Nonprofit Inc. The CBP Nonprofit Inc. is a true spine research foundation, and it is a true nonprofit organization. We follow all government bylaws and regulations for nonprofit organizations. We also have, as part of our nonprofit organization, an IRB, an institutional review board that is not affiliated with CBP. These are independent members, and what this IRB does is they approve or deny the ethics of our research projects that we propose. That being said, what we've done with CBP Nonprofit over the last several decades is we've published a plethora of peer-reviewed scientific spine-related research articles. These articles range from analysis articles to biomechanical experimental models to animal models to human intervention and treatment intervention outcome studies. What we're doing in these weekly video series that hopefully you've been watching is I'm personally reviewing each one of our projects, going through the publication in a pointed manner. So that way you get a true understanding of what the actual research project was all about. Many people don't want to download and read the available articles, even though I think it's a very, very important thing. You're going to pick up more from the research articles maybe than me going through it, because obviously I'm going to give you the summary and the cliff notes. So this week's video is what we've done is we've picked one of our publications out of the Archives of Physical Medicine and Rehabilitation. You can see we've been in there 3 separate times. We're going to go through our first publication in that journal. This week 17 video is on CBP non-randomized clinical control trial using the primary intervention of Pope two-way cervical extension traction to increase the cervical curve. This was published in 2002 in the Archives of Physical Medicine and Rehabilitation, volume 83, pages 447 through 453. I was personally the lead author on this. Dr. Rene Caillet, very famous physical medicine doctor, physiatrist, formerly with USC. My late father, Dr. Don Harrison, and his advisor, PhD advisor, Dr. Tadeusz Janik, and then the late Dr. Bert Holland, our statistician, formerly from Temple University. This particular project is actually very dear to me. This was the first time I ever truly managed a clinical control trial out of one of my practices. And of course, my collaborating and senior authors dramatically helped me guide the project, data analysis, writing, things like that. But really, this is the first project that I truly managed primarily out of my facility, and this project was my personal idea. So, without further ado, let me start with an introduction. First and foremost, the cervical curvature from the side, what we call the cervical lordosis. This cervical curve is extremely important for health, people's well-being, and it correlates and relates or causes many health disorders and many diseases. I'm not going to go through each one of these papers with you, but I do want to summarize the topic so you get an understanding of why we would pursue a trial, an intervention to change the altered cervical curve in a patient. What is the relevance of doing this? If you look at this, we wrote an X-ray guideline in 2009. It was called the PCCRP X-ray guidelines. This guideline is a legal guideline accepted for inclusion in the National Guideline Clearinghouse. If you go to the website www.pccrp.org and you look at section 10, page 181, you'll see the following information and the supporting references for this. Altered cervical curves from the side have been shown in different studies to correlate to, contribute to, or cause the following things: acute and chronic neck pain, headaches. They've been associated with poor mental health status, whiplash-associated disorders, meaning neck pain, headaches, arm pain, degenerative joint disease, temporomandibular joint problems following a motor vehicle crash collision, segmental instability, degenerative joint disease or spine arthritis and disc disease, TMJ disorders, altered range of motion and altered movement patterns in the spine segments, altered respiration problems and different respiration syndromes like sleep apnea, asthma, things like that, radiculopathy, arm pain, numbness, tingling, weakness in the hand, arm, etc. Post-surgical patient outcomes. Do you still suffer with post-surgical pain and impairment even though the surgeon relieved the stress on the spinal cord and nerve root via decompression? Do you still have pain and impairment following the surgery? The potential for injury after either a traumatic whiplash type of event or a direct compression load to the cervical spine. The cervical curve has been shown to contribute to, cause, or be related to all these conditions in the literature. For example, I'm only going to go through one paper, and then we're going to dive into our current project. In 2011, a breakthrough study came out of the neurosurgical literature. This was the first ever double-blind, prospective, randomized trial to look at outcomes following surgery. Does the cervical curve relate to post-surgical pain and disability? Here's what they did. They took 122 patients and they followed them prospectively for 3 years. These patients received a single level decompression and a fusion. And they compared two different types of fusion constructs. One was what's called a straight graft, meaning when I put a plate in, it's straight. It's not contoured to achieve lordosis at the segmental fusion. And then the other one was a lordotic plated fusion. So they're trying to determine, number one, does it matter what surgical construct or piece of material that we put in? Is it relevant to put a straight surgical construct in, or is it more relevant to put a curved cervical construct in? Of interest, they found no difference between the two surgical devices. What the finding was that was important was no matter what device was used, if they maintained the segmental lordotic curvature of the fused area, that patient did way better on their pain and disability, regardless of what type of surgical device was used. Conversely, when a patient was fused without proper lordosis at that segmental level, these are the people that had chronic, long-standing pain and disability 3 years after the surgery. So here's what they identified. Patients who had maintained or improved the segmental sagittal alignment, that's the curve, regardless of the type of surgical device used, achieved a higher degree of improvement in the short form 36 questionnaire, that's the SF-36, or the RAND-36 health status questionnaire, on the physical component score of that RAND-36, and the neck disability index. Statistically significant findings were confirmed. This was in 2011. Now, I want you to know our project came out in 2002, about 10 years earlier. So we've been doing this work way longer. We've been seeing clinically this work to correct the cervical curve improves outcomes. Well, the surgeons have been after this too, surgically for many years, but this is the first double-blind randomized controlled trial to actually specifically look at this and show without what I would call without a doubt that there is an important relationship between altered cervical curve and poor outcomes after surgery. Okay, that being said, most people in my opinion are not surgical candidates. Most people, what we need to do is reestablish the cervical curve via conservative methods. If those methods fail, then the person can be a candidate for surgery. It doesn't yet necessarily work the other way around. If you go to a surgeon first and you get hardware in you, there's not a lot we can do from a corrective care point of view. We can do some, but there's a difference. Now that neck is now physically different than what it was. So in my opinion, unless it's an immediate surgical crisis, most people need to try this type of work first. So this is what we're investigating in this 2002 project. We're looking at a new method of extension cervical traction designed to increase the segmental and total angle of cervical curve. We're looking at how effective is this, and then also, is this relevant to outcomes in chronic neck pain? Okay? So there's two parts of this, and we'll look at what we can actually conclude after this project. This is a picture of the cervical extension traction. We call this Pope two-way. A chiropractor named Mike Pope designed this in the late 1980s after consultation with my late father, Dr. Donald Harrison. So my dad had design input into this, but Dr. Mike Pope spearheaded this particular piece of equipment. Dr. Mike Pope practiced in Troy, Ohio for many, many years. He's now retired. This is two-way traction. We have a pull backwards that fixes the head back into extension with translation of the head backwards. We can also change the angle on this and pull vertically if we need to at first to provide some distraction or relief of the symptoms that a person might experience. Also, what this does, I have a strap around the posterior aspect of the neck, and this pulls forward in the cervical spine, forcing a cervical curve into the neck. There is weight over a pulley mechanism. Now, the angle of this front pull is dictated by the exact shape in the cervical spine. Do you have a loss of your curve down low, in the middle, or in the upper cervical spine? So we would change the angle based on the type of neck that we have. So shown is two example neck x-rays. One of these on the reading right is going to be pulled in the lower neck. The other one is going to be pulled more in the mid and the upper neck. So just to give you a background of what we're trying to do. So we're physically loading the cervical spine to change the shape of this column. We'll talk about why we do that, how we do that coming up. Study methods, this particular project. This is a prospective, non-randomized clinical control trial, meaning we are not going to randomly assign people to one of two groups. We are going to allow them to self-select. Do you want to be in a treatment group? Do you want to be in a control group? So it's non-randomized self-selection of the patients, okay? Now we have 30 prospectively selected chronic neck pain patients that do not have arm pain all the way down to the arm into the hands. They can have upper shoulder and scapular pain, but they can't have true radicular signs and symptoms. These patients also have loss of the cervical curve. Loss of the cervical curve is defined as 1 standard deviation below our published normal data that was in Spine 1996. Specifically, curves under 25 degrees from C2 to C7 were included in this project. If you'll notice, only 9 subjects were between the range of 16 to 25, and the majority of the subjects, 2/3 of them, had curves well below 25 degrees. They were well below the mean averages in asymptomatic people. They were below 16 degrees. The treatment group, we applied chiropractic spinal manipulative therapy using a modified diversified technique for the cervical spine. Spinal manipulative therapy was provided in the first 2 to 4 weeks, and it was terminated after that first 2 to 4 weeks. We do that to improve range of motion and decrease pain and decrease muscle spasm in patients prior to doing this cervical traction. So 2 to 4 weeks of spinal manipulative therapy to the cervical spine. The treatment group also received Pope two-way extension traction to increase the cervical curve. They did this 3 to 5 times per week for the duration of the study, which lasted up to 10 weeks. The average subject received 35 intervention sessions over the course of 10 weeks. So you're looking at an average of 3.5 sessions per week. That's important. After this 35 visits, a minimum of 1 day later, sometimes up to 3 days later, the subject came back in, received a second examination and an x-ray. Okay? So we have 35 interventions, including the first 2 to 4 weeks of spinal manipulation. So the first 2 to 4 weeks of the traction also included spinal manipulation, but then it was stopped after that. Okay, then we have a second exam, a minimum of 1 day after the 35 sessions. We compared that treatment group to a control group, volunteers with the same condition that said, I'll be in the control group. We have 25 control subjects matched for age, height, weight, and pain. These subjects received an initial examination and then a follow-up examination with no treatment, no intervention. They kept their same regimen that they'd been doing previously prior to the study, and then we followed them for 8.3 months. Okay? We followed them for a lot longer than the intervention group. Why? We wanted to see how long this condition may or may not stay the same with no intervention. So they have chronic neck pain, loss of the cervical curve, and we're going to follow them with no care for up to 8.3 months. Outcome measures. Sorry, this is a typo. It's not the NRSS, it's the NRS, Numerical Rating Scale Pain Score. Okay, 0 to 10. 0 is absolutely no pain whatsoever. 10 is severe, incapacitated, bedridden. You can't even be in the study because you're in bed. A lot of patients want to say they're a 10. No, you're not a 10 if you can get out of bed. It doesn't matter if you struggle. If you get up out of bed, you're not a 10. That's the way the pain scale works. You're a 10, you're carried in on a stretcher. You're in the hospital. That's what a 10 is, okay? So 0, no pain, all the way up to incapacitated, okay? So outcome measures, X-ray and pain scales, and then statistical analysis looking at between and within groups. So we did two-sided, two-sample t-tests and two-sided paired t-tests using the software Minitab that was available at that time. Additionally, in the treatment subjects, after the 35-visit examination, we then followed them for another program with no care to see how long any changes that were achieved in the cervical curve and pain, how long were these maintained. So 25 of the 30 subjects in the treatment group, 83.3%, were followed for 15.5 months after their post X-ray. So after their 10 weeks of treatment, stop, no care, follow them for another 15 and a half months, repeat a re-examination, repeat an X-ray to see what happened, okay? Here's the measurements of the cervical curve we're looking at. We're looking at total and segmental angles of curve. Now, we've already discussed the reliability of these line drawings in previous projects, so you already know these are reliable. I had to do the reliability studies first before we can ever do this kind of experiment looking at changes in the cervical curve. We know our lines are reliable. We can now use them in this particular project. We're looking at segmental and total angles of curvature. Okay, two-way traction. Here's how we use it. Number one, the strap is placed at the level of the abnormal cervical curvature, where it's maximally displaced or where it starts to become abnormal. It's either going to be in the low neck, the mid neck, or the upper neck. That's number one. Number two, the angle of pull matters, both on the front and the back. Okay? If somebody has a lot of neck pain, we're going to pull higher in the back. If they can tolerate more extension, we lower it down to where the back pull is horizontal or parallel with the floor, so we get a lot of cervical extension. Number two, the weight matters, the weight on the front. We start the average adult with 15 pounds on the front pull for a minimum of 3 minutes. Now you might think 15 pounds is too much. That's the weight of your head. 15 pounds is the weight of your head. It's not a big deal. We go from 10 to 15 pounds usually to start with people. Smaller frame people, we can start with 10 pounds. Larger frame people, we're going to go up to 15 pounds to start. 15 pounds is minimum. Our goal is to work a patient up over consecutive visits to where we go from 3 minutes to 10 to 20 minutes. Okay, 10 to 20 minutes of sustained loading. And then we also have to start to increase the weight. We have to get the front pull to a minimum of 25 pounds on the front. Better to have about 40 pounds on the front. Okay, so this says weight is increased to patient tolerance. Once they can achieve 10 minutes, then we try to go up in weight and gradually try to increase the time up to 20 minutes. The goal is to get people close to 40 pounds for 10 to 20 minutes. Closer to 20 minutes is better, okay? 10 minutes is minimum. Now, if this bothers your jaw, so if you get TMJ disorders, there's other harnesses that we use around the jaw. We can open up the mouth. We can take pressure off the jaw itself. So shown is the example of how we do this. Okay, why do we have to apply sustained loading over time? Why can't exercise alone or a quick adjustment into the neck change the neck curve? It is not my opinion, it's biomechanical data. Biomechanics of soft tissues proves that soft tissues do not, I repeat, they do not permanently change their shape and size in short loading applications. Soft tissues are viscoelastic. In the first load application, your tissues are elastic. They stretch and they give under that load. They have to. Once you relieve that load, they recoil. It's called elastic recoil energy, or what we call in mechanics of material, recoverable strain energy. It just so happens that the minimum time you should load spine tissues for to get any type of non-recoverable strain energy that's reasonable is a minimum of 5 minutes. 5 minutes is minimum, but you don't get much. If you load a spine for 5 minutes, most of that loading, when you see a deformation, most of that deformation is going to be elastic recoil, recoverable strain energy. I have to go to at least 10 minutes to see a great difference. So although you see some at 5, it's not much. When you go up to 10 minutes, the elastic recoil is not complete. You see what's called non-recoverable strain energy. It's called hysteresis. It's called an exothermic reaction by changing collagen-hydrogen bonds. Okay, it's an exothermic reaction, breaking some of the collagen-hydrogen bonds. And breaking doesn't mean tissue damage. It just means the bonds themselves are deforming and then breaking the collagen-hydrogen bonding. So we get an exothermic reaction. I get deformation of the tissue. It has to be done for 10 to 20 minutes. Now, if that's too much information for you, I'm really sorry, but you can look up biomechanics of soft tissue. You can look up a topic called rheology, fluid flow of tissue. It's true biomechanics. There's math analysis that goes along with this. In reality, what we have to see is a minimum of 10 minutes up to 20 minutes to get what's called non-recoverable strain energy. This is a graph we put together to show you extension of the cervical spine in traction over time in minutes, and then how much of this is elastic versus how much of this is true shape change or length change in the soft tissue. When I load somebody for 20 minutes, the tissue deforms on the graph up to here, here, and here. Now these three lines are different ages. We have older spines and younger spines shown in this particular graph. Okay? Some spines are more elastic than others. Some spines are more stiff and require more load to change them than the others. Well, when I release the load after 20 minutes, I get this initial elastic recovery, and then the graph plateaus. This is what we want, this area in here where it doesn't come back down to the origin. That's what I call my non-recoverable strain energy. I want to optimize that when I want to change the cervical curve. You have to do traction. You have to do sustained loading. This is why we do this. It's biomechanically sound. It is true evidence-based application of how your spine behaves under load. Now, back to the study. Group comparisons. This is looking at men and women in each group. So a treatment group and a control group. We separate them out by gender because our groups were not identical for gender. So we got to see, is there a gender effect here? Okay, so we are controlling for gender. One way we can do that is look at the table differences between men and women. Okay, so control group, males. Treatment group, males. You can see the age, height, weight, and initial pain. There's no statistically significant differences between the groups in their initial pain. However, the follow-up pain, 35 visits after traction, and then 8.3 months later in the control group, you can see that there is a statistically significant difference between the two groups' pain, meaning that the treatment group, their pain has been reduced. Okay? Their pain has been reduced. Females, control group 13, treatment group 25. We match them for, sorry about the little home button there. We match them for age, height, weight, and initial pain. The groups are matched initially. However, look at the post-pain response. The two groups are dramatically different in the post-pain, meaning the traction plus the spinal manipulation for 2 to 4 weeks statistically improved people's chronic neck pain compared to the natural history of it. If you just let somebody go on their own, say, oh, I'm going to deal with my neck pain on my own like I've always been doing it. Guess what? 8.3 months later, a 3.7 is a 3.9. You're still in pain. You chose to do the same thing you've been doing. You should not expect it to be different. Chronic pain does not get better on its own. Sorry, you know, patients out there, you need this, you need a reality check. Now, I'm not talking about acute pain. I'm talking about people that have had chronic recurring neck pain. These are the people we're looking at. If you continue to do the same thing you've always done, guess what? 8 months later, you're going to be the same. You know, it's not rocket science. The controlled group didn't change their pain. The treatment group, their pain goes from a 4.5 in the females down to a 1.6. That's a strong difference. It's statistically different now between the groups. So both men and women had improvements in pain. But you will notice that women on average had higher pain than men. Okay, for whatever reason in this population, the women had higher pain than men initially. Both groups, though, in the treatment group, men and women, got improvement in their chronic pain. Both groups in the control group stayed the same. The men, 3.5, 3.6. However, the men in the treatment group, they're about 50% better in their chronic pain. Study results, the control group. No differences in the control subjects' natural history of their pain, and no difference in their x-ray. This is important. Here's the control group. Pre-x-ray means their initial evaluation. This is the head translation, C1 to T1 or C2 to C7. No change. This is 1.1 millimeters. That's within our standard error of measurement. P is greater than 0.05. So people's head translations stayed the same. Atlas plane line stayed the same, 16 to 17, statistically the same. Segmental angle, C2 to C3, 4.8, 4.8, statistically the same. You go all the way down and then look at the total angle of curve. The control group, the total angle of curve, about 10 degrees. That's quite a loss of the curve. Normal is between 30 and 42 in most studies that we've done. So these people are well below normal. The post x-ray, 10.8 degrees. No change. Your curve stays the same. It doesn't get better on its own. People go, oh, well, I was just standing that way on the x-ray. 8.3 months, do you think that you stood exactly the same just because you controlled for that? Or do you think it's actually a true stable finding? You didn't just stand that way. It's the way you are. It didn't change on its own, and it didn't just look like that because of an accident, right? And I don't mean an accident like a car crash. I mean, you know, an artifact. When we take an x-ray of somebody, it's statistically repeatable from session to session unless we intervene. You know, people are funny. You have to show them this data. You have to say, you weren't just standing like that. I mean, if you really want to, we'll take another x-ray and you can do your best to stand different, you know, but it's going to look the same unless you force it to move, right? So the control group, identical findings in their x-ray. Here's the treatment group that got spinal manipulation for 2 to 4 weeks and then the traction. Statistically significant changes all the way down except one of the relative rotation angles. The C6, C7 relative rotation angle did not change of interest. Maybe that's due to the location of the traction strap, whatever it is. But that, if you look at it, that one actually had a pretty reasonable curve to begin with. So it went from 4.1 to 4.7, no change. Of interest, it should be a minimum of 6 degrees at that level according to our data in our CBP model. Look at the total angle of curve, C2 to C7. 12.4 to 26.6. That's a 14.2 degree increase in the cervical curve in the group that got care. Okay? This is an important finding. Statistically increased the curve by 14.2 degrees. Okay? Now we stop care and follow the treatment group for another 15 months. So I want to see, is this a stable response? What we find out is 25 of the subjects out of 30 in the treatment group come back for long-term follow-up. We lost 5. That happens, okay? We still have 25 subjects. If you look, here's these 25 subjects. Their head translation. The post x-ray, not the first x-ray, the post-treatment x-ray. No statistically significant changes in the translation. However, we're losing a tiny bit of the upper cervical extension, atlas plane line. We're losing a little bit of the C2, C3 angle. We're losing, no difference in these angles, and then we're losing a little bit in the total angle of curve. We lost 3.7 degrees in the total angle of the curve. Most of that came from the upper neck. That's probably as a result of a little upper neck extension. In reality, what we've shown is we've maintained the mid and lower cervical curve, which is primarily what we're interested in. The upper cervical spine, skull to C2, is strongly influenced by head position, head flexion and extension. So this data strongly suggests that the curve that we've corrected in the mid and lower cervical spine is now maintained. So we've only lost 3.7 degrees of the total curve correction, meaning we've still got, if you look, the ARA, we've still got 23 degrees in that neck. And it started, if you remember, it started at 12.4 degrees. So we've got about an 11 degree still increase in that curve. This is a very important finding, very important. Not only can we change the curve, it's stable on its own, most of it, over time without care. However, we did lose a little. The pain was also stable in these 25 subjects. They statistically maintained their pain improvement. Okay, I don't have a graph or a table for that. Here's a sample x-ray of one of the subjects. Now this happens to be one of the subjects that didn't come back for the long-term follow-up. So there are 5 out of the 30 that we lost at long-term follow-up. But you can see a relatively straight or mid-cervical kyphosis. On the pre-treatment x-ray, the post-treatment x-ray shows a 20-degree change in the cervical curve. Here's a subject that we had a long-term follow-up on. Pre-treatment, post 35 sessions, long-term follow-up. You can see this subject actually nicely maintained their curve and maybe increased just a bit. Some of the subjects will see that, a few degrees increase. Some of the subjects will have a few degrees decrease. Conclusions. Sagittal cervical traction, two-way traction with this transverse load, the posterior pole at mid-neck, combined with cervical spinal manipulation in the first 2 to 4 weeks for a total of 8 to 10 weeks total treatment, was able to increase the cervical curve and decrease chronic neck pain as compared to a control group. Increases in both the segmental and total angle of curve was found. Lordotic curve increases in the C2 to C7 angle using the posterior body lines showed 14.2 degrees change. Most of that change was distributed through the below the C2 C3 angle, which is of interest. Lordotic correction remained mostly stable at long-term follow-up. Only a 25% loss of the total curve correction, 14.2 degrees. Net loss 3.7. But again, most of that loss occurred at the top of the neck, not at the bottom of the neck, which is really clinically significant. Most people have a loss of their mid and lower neck curve. We've shown we can correct it and it's stable at long-term follow-up. However, losing a little bit of that curve at long-term follow-up still indicates the likely need for supportive care to see if we can truly maintain 100% of the correction by putting a patient on supportive care after the corrective care program, doing 1 to 2 times a month. We'll have to look at a future project that did that. In fact, I'll do that next week for you. One of the limitations of this project, number one, it wasn't a randomized trial. Patients self-selected. Could there have been a bias for that? Of course there could be a bias for that, but self-selecting is not going to make this type of group differences. You don't self-select and go into a control group, and that's not why your neck curve, didn't change, and why your neck, pain is still chronic. Okay, let's keep this in mind. This is a true non-randomized clinical control trial. It actually represents the reality of practice, where patients choose what they want to do. In a randomized trial, patients don't come to a clinic and go, I don't know, doc, why don't you pick for me? Why don't you put a computer-generated model together and select me to the treatment? That doesn't happen. So this is clinically relevant for the actual, process in a practice. Patients choose what program they want. So I guess, hey, when you choose care, this is a good thing. Look at the results you're going to get. If you choose no care, hey, it sucks to be you. You're still suffering at long-term follow-up. Great choice. Anyway, keep that in mind. This is a true research project. Sometimes I get a little colorful with this, so you got to realize that's not what was communicated to these patients at the time of the project, but looking back on it, that's the way I see it. Okay? So, 12 years later. The other thing is, did the spinal manipulation for 2 to 4 weeks in the treatment group, did that improve their curve? No. We've already gone through projects like that. Once in a while, a blind squirrel finds a nut, and classic traditional chiropractic segmental adjusting might make a great change on a case-by-case basis. But if you look at a clinical control trial, prospective studies, they don't get anywhere near this type of change that we got in the group that got the traction combined with the manipulation. Was the manipulation important? Sure, it was important to help manage the patient's condition, to improve neck range of motion, to decrease muscle spasm, to improve pain. It helps traction, but by itself, it does not change the curve. We already know that. We did a study on that in 1994. It was one of the first few projects I went through. I'm going to refer you back to that early video. Look that up. The other thing is, what you have to realize is in this project, I did not do my own examinations. Okay, so I was not in there doing the examination. In fact, the exams were performed by different evaluators that were blind to whether or not the subjects were even in a study. So these were interns of mine at my Elko, Nevada practice. They did not even know that the subjects were part of an experiment. They just knew that they had to do an examination or a re-examination on these subjects. They didn't know who was part of a clinical trial. Okay, they were blinded to that. This is a very important aspect of this study design. I didn't go in and do my own evaluations. I'm the one that knew who was in the treatment group or the control group. Nobody else did, right? The examiners didn't know that. So they couldn't encourage somebody to, hey, you're part of a treatment group, please report your pain better. That was not part of the scenario. These were actual exams that were performed, and they're blinded to whether or not they were part of a study. Now, of course, the exam doctor knew whether or not they had received treatment or not. They just didn't know if they were part of the study. Okay. That concludes this week's clinical control trial. This is a very important project for us. What can we conclude? We can change the cervical curve, and we can change the course of chronic neck pain by doing a program of CBP extension traction designed to improve the cervical curve. If you look at the chronic natural history of neck pain and loss of the cervical curve, it doesn't get better on its own. It requires intervention. We've shown that we can change the natural history of neck pain at long-term follow-up. This is a big deal. If you're a patient out there or a doctor out there, please consider the following information. This information, if you're a patient, you need to go to a chiropractic biophysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy-to-use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work. Okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you. And if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP nonprofit will get 0.5% of all your purchases, which is a big deal. It adds up. And until next time, we'll talk to you later, and I wish you great luck and great success in whatever you're doing.